Good afternoon to one and all, and thank you very much for the invite. So, warm welcome, warm greetings from my center, Tangam Cancer Center, Namakkal. So, I'll be talking about basically the selection of first-line therapy for RET in NSCLC. A good background has already been set up by Dr. Trupti, what to do, how to get to the RET, and I'll tell you what to do next after we get the RET. So, we know that the lung cancer is a common cancer and it is associated with high mortality. We are helped by the use of molecular markers and also the targeted and immunotherapy, which has changed the landscape. And we now see the survival not in few months, but in few years. And we talk about 5-year survival in lung cancer, even in stage 4. So RET alterations are seen in approximately 2% of all human cancers. In NSCLC, as already elucidated, it was found in 2012, and we have progressed after that. It is typically seen in younger never smokers and adenocarcinomas, but it is not restricted to it. You have to see RET in each and every patient of your NSCLC. The agents, if we describe, there are a lot of them. We started with multikinase inhibitor like cabozantinib, vandatinib, sunitinib, and the list goes on and on. Everything was used which was available, but unfortunately the response rates were up to the tune of 20 to 30%. PFS very dismal, 4 to 6 months only. Overall survival was not going beyond what we see with the standard chemotherapy, and it needed a lot of dose reductions, almost to the tune of 75% because of the toxicities, and even 20% discontinuation rate. So probably it was not the best choice, and we had to do something more. So chemotherapy is always there, a backbone, pemetrexed platinum, which have shown good responses. Coming to immunotherapy, unfortunately, we don't have good response rates, only 6%. So we have to come to something which is very selective, and off-target action can be reduced. So there comes sulpertinib and pralsetinib. So this comes with the phase 1-2 trial, Libretto 001, again multi-center open label. Phase 1 determined the RP2D of 160 milligram twice daily. Endpoint was to find ORR and DOR and PFS safety. We can see out of 253 all solid tumors, almost 100 out of the total 500 plus patients, 250 were around NSCLC, of which majority of had some kind of platinum therapy or some non-platinum therapy, and some were treatment naive. When it was seen according to the baseline characteristic, we can see the majority, as already elucidated, the commonest fusion partner was KIF5B RET. This is a response rates, and we can see a very beautiful response rate. We are talking about 20% with MKI, that is multikinase inhibitor, and now it is 64%. It is almost 3 times than what we would achieve with the multikinase inhibitor. Not only that, the durability of response is excellent. We can see the duration of response was 17.5 months and PFS was 16.5 months. So definitely it had a good tumor response. And not only that, it showed the anti-tumor activity regardless of whatever was the prior therapy, whether it is chemotherapy, it is immunotherapy or multikinase inhibitor, anything. This was seen in untreated. These are the naive patient, and I don't see any bar which is above 0. So this is like practically almost everybody is responding. ORR was 85%, good durable responsibility. The median has not yet reached. 1 year PFS was 75%. So this is astonishing. I mean, it is really very good. Coming to the something which is probably the liquid testing, and we can see that both C1D15 and C5D1, the response was almost more than 90% reduction with the use of this molecule. So duration of response, again, as I already told, 17.5 when PFS was 16.5 months, good response of 63%. So it was actually plus for everything. And these results were irrespective of whatever was the previous therapy which was used, and also whatever was the fusion partner. So irrespective of what was the fusion partner, it showed good responses. It was active intracranially also. So this is something we are always worried. Once the patient progresses in the CNS, we have hardly much to do. But this molecule comes for rescue, and it has shown almost everybody has responded, with 3 patients actually going into complete response. So switching the gear to pralsetinib by the ARROW trial, again almost similarly done trial. phase 1 followed by phase 2 with getting RP2D of 400 milligram once daily. Again, out of around 533 patients, 179 were lung patients, 132 were for ITT. We can again see the commonest was KIF5B. And again, a very beautiful response, almost 66% ORR in treatment naive patient, already treated patient, 55%. Almost everybody responded. And again, this anti-tumor activity was irrespective of whatever you have used first, or the fusion genotype, or whether there was a presence of CNS meds. So beautiful duration of response. Again, this is just to show that even in different organs, like pancreatic adenocarcinoma, cholangiocarcinoma, which are the worst of the tumors, if we find a RET, almost everybody responded. So not only in lung, but other tumors where we actually use NGS and we find RET, we can use this selective RET inhibitors. It is again active against intracranial brain metastasis also. So this is just an update for sulpractinib. Total 233 patients. Those we know ORR was better, 61 in priorly treated and 70% in the new patients, naive patients. PFS was, median PFS was 17.1 months. This is not OS, this is PFS, 17.1 months. Median OS is not yet reached. Almost 3/4 patients are still alive at the end of 17 months of median follow-up. Intracranial response is also good. Duration of response median was 9 months. Dose reduction was just 2%. And dose discontinuation was 6%. This is just single this thing. So this was already elucidated in May 2020 and September 2020. We got these 2 drugs as an FDA approval. This is also again discussed. We know that in RET, immunotherapy alone probably is not a good choice. I'll skip this resistant part because it has already been discussed a lot with by Dr. Akhil. Coming to the new agents which are going to be there in the future. There are good phase 3 trials which are ongoing. Liberto 431, Accelerate RET, Liberto 531. They are actually comparing selective TKI versus multikinase inhibitors or a standard of choice like chemotherapy or chemotherapy plus immunotherapy. So we'll await this results and probably we are going to get much more armamentarium for RET. So we have to keep the safety in mind always, but fortunately these patients are doing very good. 10% and above grade 3 is just hypertension, neutropenia. Rest of the things are less than 10%. So a beautiful drug, less off-target side effects. This is what it shows. Monitoring again, very specific for hypertension. Do it baseline, check after a week, and then you can do it monthly whenever the patient comes. Hepatotoxicity again, monitor at baseline, 2 weekly for next 3 months, and then as and when required. And we know how to do the dose modification, which is very, we are used to it. Again, for the ILD and QTC. So selection tips are, if possible, always go for the RET specific inhibitor. If not, then probably cabozantinib is one of the recommended by NCCN. You can't do both of them. Go for the standard chemotherapy, PEM plus platinum. And probably in future, we'll have a combination of chemo plus immuno, or maybe even chemo plus selective RET inhibitor also. So thank you for patient listening.
Thank you, Dr. Bhavesh, for giving us those practical tips with that comprehensive presentations. So resistance, we have already had that presentation. So now next presentation is Dr. Omashri Shetty. Dr. Omashri is Assistant Professor and Scientific Office at Tata Memorial Hospital, Mumbai. She will be speaking about interpretation of exon 20 insertion. It is a virtual presentation.